Salvage HoLEP has been previously reported as an effective and anatomical procedure. Several publications have discussed the feasibility of Salvage HoLEP for recurrent adenoma after non-anatomical prostate surgeries. Recurrent prostatic adenoma has become more common after adaptation of new techniques which cause asymmetrical prostate volume reduction. Challenges during Salvage HoLEP include disturbed anatomical landmarks, absence of clear surgical limits, with possible scarring and fibrosis that hinders plane development, and finally doubt about sphincter integrity from the previous procedure. We present the case of a 67-year-old male with obstructed urine flow post-bipolar TURP. The key for successful HoLEP in this case is to identify the following anatomical landmarks: the external sphincter ring, the verumontanum, the bladder neck, and finally the surgical capsule, which will appear after plane development. Here is a cystoscopic view of our present case. The sphincter and verumontanum appear intact. The prostatic lobes are asymmetrical, with mainly anteriorly bulging adenoma. We follow a stepwise approach of HoLEP using the veil-sparing technique that was previously reported. For the sake of learning, we use an abbreviation to define the consecutive steps. It pass A, B, C, D. I for incision and T for trough creation are bypassed in this procedure due to the absence of the median lobe. So we proceed to P, plane development, which is done by a mucosal incision lateral to the veru, following the apical bulge. Then laser fiber is withdrawn, and we bluntly enucleate the lateral lobe using the beak of the scope, developing the plane between the surgical capsule and prostatic adenoma. Next step is A, apicolateral dissection. The scope is rotated and the laser fiber comes at 12 o'clock, using combined blunt and sharp dissection to separate the adenoma from the capsule. Then S, sphincter release. Way proximal to the sphincteric ring, we start cutting a mucosal strip from 12 o'clock toward the plane we previously created, preserving a veil of mucosa to cover the sphincter. Then A, anterior dissection and commissurotomy, in which we connect the laterally created plane with anterior commissure, riding toward the bladder neck. Next step is B for bladder neck dissection, using the laser to sharply dissect bladder neck fibers from 12 to 9 o'clock position. Then C for C-shaped basolateral dissection, by circumferential cutting all around the base of the adenoma in a C-shaped fashion. The end of this step is identification of the ureteral orifice. Then D for detachment of the adenoma after flipping toward the bladder, so the residual basal attachments are stretched and easier to be cut by the laser fiber. The exact same sequence of steps is followed to enucleate the other lateral lobe. And finally, morcellation of the adenoma is attempted, while ensuring adequate irrigation. Here is the final view showing wide prostatic fossa and intact sphincter. So to conclude, HoLEP as a salvage procedure is safe, effective, and fits different scenarios, regardless of anatomical distortions secondary to previous interventions.